Hello again and welcome back to Karlee's farm. Today we're going to talk about analgesics or painkillers. I'm going to only really cover nociceptive pain. We're not going to talk about neuropathic pain, mostly because the therapies that we use to treat neuropathic pain are primarily agents used to treat other conditions. So that's things like anti-epileptics and antidepressants. And whilst I won't talk about them today, when I do talk about them, I will talk about their role in neuropathic pain when I talk about them in their respective groups. So today we're going to talk about nociceptive pain. We're going to talk about the three main groups of drugs that we use to treat nociceptive pain, and that is the non-steroidal anti-inflammatory drugs and the COX-2 inhibitors, which you can see here, paracetamol, and the opioids. So we're going to start with the non-steroidal anti-inflammatories and the COX-2 inhibitors. These two classes are sort of almost like one big class in terms of their role in treatment and their indications, etc. They're used relatively interchangeably, but we'll talk about the differences as we go through. So again, it's really important here that we focus on physiology, and once we understand the physiology, we can understand the pharmacology and how and why it works. So if we look at the COX pathways, there are essentially two COX pathways or two COX enzymes that are important physiologically, and that is COX-1 and COX-2. So the process via which COX-1 and COX-2 are activated is primarily inflammation, particularly for COX-2. It's inflammation that sets this pathway afloat. And for COX-1, it's inflammation, but it's also other physiological processes too. So the process is that as we go down, COX activates prostaglandins. So in the COX-1 pathway, prostaglandins are activated, and physiologically they cause platelet aggregation, they cause vasodilation, they cause renal vasodilation, they cause reduced gastric acid secretion and increased gastric mucose production. So they're protective for the gastrointestinal tract. The COX-2 pathway primarily, so very similar pathway, arachidonic acid to prostaglandins, and COX-2 is responsible for the production of prostaglandins here. So in this pathway, the COX-2 pathway is primarily inflammatory mediated. So as we can see here, COX-2 is responsible for the production of these prostaglandins that are pro-inflammatory, vasodilatory, and renally vasodilatory. So similar to this group, but they don't have the gastric acid or the gastric mucosal activity, and much less platelet aggregation activity than the prostaglandins in the COX-1 pathway. So as we can see here, the non-steroidals are non-selective, meaning they will block both COX-1 and COX-2 pathways. The COX-2 inhibitors are selective to COX-2, to the enzyme, and so only affect the COX-2 pathway. And that's really important because that then influences what the side effect profile of these agents will be. So you can see here clearly in the COX-1 pathway there's more side effects related to the action of the prostaglandins that are involved in this pathway. So because we will be blocking platelet aggregation, we're more likely to get bleeding. Because we'll be blocking vasodilation, we're more likely to get vasoconstriction. And in fact also fluid and sodium retention. Because we are blocking renal artery vasodilation, we'll get reduced renal perfusion because we'll be constricting the blood vessel that goes into the kidney and reducing the amount of blood that can get to the kidneys. And because we are blocking the reduction in gastric acid and the increase in gastric mucus, then we are getting increased risk of gastrointestinal bleeding and gastrointestinal ulcers. Now, similarly, on the COX-2 side, we still have vasoconstriction, so we still have cardiovascular risk, and we still have reduced renal perfusion, so we still have a risk of renal injury or acute kidney injury. But we have much less gastrointestinal side effects compared to the COX-1 agents. And this is why the COX-2 inhibitors are used for patients who have got a gastrointestinal bleeding risk or a history of gastrointestinal bleeding as well. These agents really are primarily used as first-line agents in pain. I'm going to talk about the WHO pain ladder in a moment when we move over to opioids, but non-steroidal anti-inflammatories and the COX-2 inhibitors are very commonly used for treating pain. They are readily available, so some of the non-steroidals, like ibuprofen, for example, you can get at the supermarket without a prescription. They've got a fairly they're a fairly safe medicine to use short term. Again, you have to be careful of the side effects like we've listed here, but in short-term use and in recommended doses, they're fairly safe. There are other non-steroidal medicines that you need a prescription for, and there's a lot of different ones, naproxen, diclofenac, and one particular one is no better than another. So some people, if one hasn't worked for whatever reason, then it's reasonable for people to try a different one. And each of them have slightly different risk factors in terms of these key side effects. So some are safer in cardiovascular disease than others, and some are safer for gastrointestinal bleeding risk than others, etc. So there is some relative differences between them. So that's the non-steroidals and the COX-2 inhibitors, which, as I said before, sort of really fill one big group realistically. The other medicine that is a non-opioid that is used commonly for pain is paracetamol. Now, paracetamol, again, really readily available for both adults and for children. You can buy it from the supermarket, and it's got a really great safety profile as a general rule. So if it's used as recommended in recommended doses and for recommended periods of time, then it's fairly safe. The one, I guess, concern with paracetamol that we think about is the risk of hepatotoxicity or liver toxicity. Paracetamol is cleared by the liver, and so that is, if it's taken in overdose, it can cause liver failure, and that can be fatal. That can cause death. So we keep a track. We monitor people's liver function if we're worried about them and how much paracetamol they're on, or if people come into hospital having taken an overdose of paracetamol, it's very quick and have to manage that very quickly. Interestingly, even though paracetamol is really common and used all the time in practice, we're still not 100% sure how it works, but it's thought again to be prostaglandin related, mediating prostaglandins probably centrally. So it does treat pain, but it is not anti-inflammatory. It also treats fever, as do some of the non-steroidals. Some are better than others. So ibuprofen, for example, is used to treat a high fever too. Okay, so we're going to move over now to the opioids. I don't want to take too long, so we're trying to make this quick. So this isn't exhaustive, but this is hopefully enough to get you started. I'm going to zoom myself over here. So as I mentioned before, I really wanted to remind you about the WHO pain ladder. So the WHO pain ladder is basically it's a ladder really, isn't it? It's a stepwise approach to managing pain. And so the bottom rung where we mostly start are the non-opioids, things like paracetamol and the non-steroidals like we've just talked about. There's a middle step here called weak opioids, which is a bit of a funny one. It includes medicines such as codeine, which is technically an opioid but is considered a weak one, and tramadol, which again has activity at the opioid receptor but is considered weak. And then the very top rung of the ladder for pain management are the opioids. So we're going to talk about the opioids now, and there's a few things I think that are important. So essentially the opioids are any drug that acts like morphine, and that is acting on an opioid receptor. Now technically there are multiple opioid receptors. I've got a couple of them written here, but the main one that we really care about, or that we really think about in terms of clinical activity for analgesic activity, is the mu receptor. So it's sort of the main one that we really focus on, but there are the others. All of the opioid receptors are G-coupled protein receptors. They reduce neuronal excitation, essentially. And as we mentioned before, the pain pathway is fairly complicated, and it actually involves a lot of different receptors. So we have talked about the COX pathways and the prostaglandins, but there are a heap of other chemicals involved too. So obviously the opioid receptors are involved, but also things like serotonin, noradrenaline, bradykinin, glutamate or NMDA receptors, GABA receptors. So there's a lot of receptors that are involved, which is why we can use medicines from other classes, so things like the anti-epileptics, to treat pain. And that's really important because some of the opioids have opioid receptor activity, but they have, in addition to that, other receptor activity that are non-opioids. So the main thing about the opioids is to understand that they treat pain, and they're a fairly strong painkiller, which is why they're at the top of the analgesic ladder. And they have some side effects that are class related, so that they will all do. And that is sedation. And I've put respiratory depression and sedation together. So they can cause sedation and respiratory depression, but they won't cause respiratory depression without sedation. So you'll always be sedated if you're going to get respiratory depression. They cause constipation, they cause nausea and vomiting, and they cause tolerance and dependence. Now, there's some other things that are interesting to know about them, and that is that some of them act on other receptors. So some agents, for example, tramadol, which is actually considered a weak opioid up here, also has serotonin activity. Tapentadol has noradrenaline activity. Methadone has NMDA receptor activity. So there are a lot of opioids that work at various different receptors as well, in addition to their opioid activity. The opioids come in lots of different routes of administration. So there is oral, there is IV, intramuscular, so intravenous, intramuscular, subcutaneous. There are patches, there are lozenges, there's intranasal, there are nasal sprays. If you can think of it, you can probably get an opioid in that form. So there is a lot of them, and there is a lot of different ways for them to be administered. So the quintessential, the sort of grandfather of the opioids is morphine, and everything is sort of compared to morphine. So there is a thing called equianalgesic dosing, and that is essentially that not all opioids are created equal. They have different affinity for different receptors, including the opioid receptors, including the mu receptor. And so you can't just swap, say, morphine and codeine. They're not the same doses. So usually what we do is we convert everything back to sort of morphine doses that are equivalent to morphine, and then we can convert opioids over based on their morphine equivalent. So I did just say that codeine and morphine aren't the same, and they definitely are not. In fact, codeine is the prodrug of morphine, meaning that it needs to be metabolized to be active. So codeine is metabolized in the liver to become morphine. Now, the enzyme responsible for codeine to be converted to active morphine is an enzyme called CYP2D6, and that is genetically variable, which means that depending on your genetics, some people will be able to convert that codeine to morphine in a normal fashion. Some will over-convert if they have an overactive CYP2D6 enzyme, and some won't convert at all, which means some people will take codeine and never convert it from its pro form into its active form of morphine. So you can see here that there are a lot of variations, particularly in pharmacokinetics when it comes to the opioids. And because they're to be an opioid, they have to work on the opioid receptor. A lot of the reasons why we choose a particular opioid clinically has a lot to do with the pharmacokinetics. So it has a lot to do with how fast it works, what route of administration it's in, what clearance mode it has. Does it need to be renally adjusted for patients with renal impairment? Is it one that might require genetic variability, might be influenced by genetic variability? So there are a lot of reasons why we would choose one over the other, but a lot of it comes down to their pharmacokinetic differences. So again, opioids are used very commonly in pain. They're sort of the top rung of the WHO pain ladder, and they are really, they're not all created equally, and we choose various opioids for various different patients for various different reasons. But there is a class effect in terms of analgesia, and there is a very kind of standard class adverse effect profile for all of them too. So thank you for coming, and I hope that this quick little toot on the non-steroidals, the COX-2 inhibitors, paracetamol, and the opioids has been useful. See you next time.